Hi, everyone. My name is Andriana Barnett, and I'm one of the nurse practitioners here at the NYU Dysautonomia Center. I joined the center last November, and I want to express my heartfelt thanks to this incredible community, my colleagues, the foundation, and all of the families that I've met for welcoming me so warmly and teaching me so much. I'd like to introduce you to our incredible team here at the center. So we have Dr. Kaufman, who is our director, Dr. Alejandro Gonzalez Duarte, who is our co-director, Lily Armstrong, who is the mental health counselor from the Stevie Schwartzberg Mental Health Program, Dr. Kazashkov, who is the pediatric pulmonologist. We have Dr. Millar, our research instructor, Dr. Kaya Dalamo, our nurse practitioner, and the person I couldn't thank enough for teaching me everything she knows about FD in the community. We have Meki Kuipers, our data manager, Leanne Lugg, our program coordinator, Lior Sanilevich, our project assistant. I'd also like to introduce you to our visiting physicians. We have Dr. El Shaikh from Egypt, Dr. Grobo Kopatel from Argentina, Dr. Roboyedo from Mexico, and Dr. Gomez from Argentina. Lastly, we'd like to wish a happy retirement to our clinical research coordinator, Jose Martinez. Now, let's dive into the next segment of our program. We'll be hearing from Dr. Kaufman, Dr. Gonzalez Duarte, Dr. Kazashkov, and Lily Armstrong.
Good morning for those in the US and in South America, and good afternoon for all of you in Europe and the US, and welcome to FD Day 2024. As you heard from Lenny, this is the 39th annual conference. Every year, the FD community meets, and in the last 5 years, we've met via Zoom, and this allows us to reach people all over the world. So today is really a day to celebrate. We have a number of things to celebrate. Particularly, there's a crucial milestone that finally has been achieved, and I would like to not only describe it to you, but ask you to join us in this celebration. And the milestone is that on June 20th, 2024, just 3 months ago, a 15-year-old with familial dysautonomia received the first dose of a drug that corrects the genetic defect. This of course, puts us directly into the era of genetic therapy. Finally, after all these years, we started the era of genetic therapy for familial dysautonomia. Now, the drug we are using is an antisense oligonucleotide, or ASO. This has been administered through a spinal injection, and in that way, it distributes throughout the nervous system, the brain, and the dorsal root ganglia outside. Now, an antisense oligonucleotide is a small piece of RNA that fixes the splicing defect in familial dysautonomia. And I will try to explain you that in a minute. The trial that we started with last 2 years, and the patient will receive ascending doses. He has already received the 10 milligrams and 15 milligram dose, and he's ready for the dose of day 112, and then will receive doses every 4 months. Now, what we are going to be measuring to see if the drug is efficacious is the gait, the ability to walk with the mobility lab, the proprioception in the knee, meaning the ability to recognize where the limbs are in space, also a number of questionnaires, and also visual function and the thickness of the retina using optical coherence tomography. Now, how did we get here? How are we here? So in the next few minutes, I'm going to try to review how we got to this point and what this drug does. So let me start by reminding you that it was in 1949, 70-something years ago, that Riley and Day, two pediatricians living in New York, described familial dysautonomia in 5 children that were living in the Jewish Orthodox community in New York. They thought, although they had no proof, because all children had the same ancestry, that this was a genetic disease. 2 years later, in 1951, the FD Foundation was established by a group of concerned parents. In 1969, Dr. Axelrod began the registry of all patients at NYU called the Familial Dysautonomia Registry. Now, with the blood samples of those patients in 2001, almost half a century after, or more than half a century after Riley and Day described the disease, Sue Slagerhout, working at MGH in Boston, discovered the mutation that is responsible for familial dysautonomia. And this is a mutation in the ELP1 gene. ELP1 stands for elongator protein 1. It had another name called IKB-CAP. Now we know is elongator protein 1. And this is the gene mutation that is responsible for FD. Now, what Sue also described and showed us was how what the problem is. You know, to make a protein, just bear with me for a minute. To make a protein, the information that is in the DNA is transcribed to the pre-mRNA, is transcribed to the pre-mRNA. This is double-stranded, this is single-stranded by a process called transcription. Now, the messenger RNA or pre-mRNA is then spliced to form the mature mRNA. Now, normally, the mRNA or the pre-mRNA is spliced to remove the non-codon or the non-coding parts of the mRNA, here shown with the white arrows. So after splicing, which is essentially cutting the pieces that are not necessary, exon 19, 20, and 21 are joined together. Now, with these 3 exons joined together, this is the mature mRNA, and a functional ELP1 protein is synthesized. In familial dysautonomia, however, there is a problem with splicing. What happens? The problem is that here in the pre-mRNA, there's also a mutation that is copied from the DNA. So the spliceosome, which is the machine that cuts these pieces, has a problem recognizing this exon-intron junction and accidentally removes exon 20, as you see here. So not only it gets rid of the non-coding parts here and here, it also removes exon 20. So when doing that, the messenger RNA is now mutant and exon 19 and 21 are joined together. Now, when this happens, the protein, the ELP1 protein, is not synthesized properly, is unstable, and essentially it doesn't do what it's supposed to do. So it is the low levels of ELP1 that are the cause of familial dysautonomia, what is responsible for all the problems. So can this splicing defect be corrected? You know, as soon as Sue and her group defined this, that was the main question. Can this defect be corrected? And can this protein that is the levels are so low, can it be increased? And the answer is yes. it can certainly be increased. And the splicing was first corrected by a small molecule called kinetin in 2007. You will hear about that by Sue. But there were some issues, and we went to the next breakthrough, which was in 2018. Adrian Krainer, working at Cold Spring Harbor in Long Island, reported that an antisense oligonucleotide was able to correct the splicing defect in familial dysautonomia in a transgenic mice. So what he showed was that here shows the splicing process in a transgenic mice. When the antisense oligonucleotide was given to the mice, the removal of exon 20 was avoided, and the animal produced a normal messenger RNA and normal levels of the ELP1 protein. So, of course, this was very exciting and made us think that this could be a possible therapy. What made it even more possible was that the same investigator, Adrian Krainer, had another successful antisense oligonucleotide with which he had been treated, or a company had been treating another genetic disease called spinal muscular atrophy. That drug is called Spinraza and had been approved by the FDA in 2015, and 14,000 patients had been successfully treated. So, interestingly, 2 years after Adrian described this antisense oligonucleotide, Stanley Crook, that is the CEO of the company that had produced the ASO for muscular dystrophy, created a non-for-profit foundation called NLOREM with the goal to provide antisense oligonucleotide treatments to patients with ultra-rare diseases, and they would do it for free for their entire lifetime. So, of course, we were quite excited and encouraged with this. And in 2021, the center started a close collaboration with NLOREM Foundation, and we were able to get them to do all the toxicology and the pharmacology studies that require a big investment in resources and in personnel. So the toxicology and pharmacology studies were done, and they were done with following a special US Food and Drug Administration pathway that authorizes testing of a drug in one patient when the patient has an ultra-rare disease and there is no commercial path for this. Now, initially, we were rejected because it was considered that FD was not ultra-rare. It had to be only 10 or less than 10 patients. We argued that, we sent more information, and finally, the program was accepted to present this IND in October 2023. So we performed a number of other administrative and regulatory studies. We were, of course, quite elated that that was possible. And in June 2024, meaning 3 months ago, this patient with FD received the first dose of the ASO at NYU. Here you see the picture, right, this was done in the OR. Here is Dr. Gonzalez Duarte injecting the ASO on the patient. This was in June 24. In August 15th, the patient received the second dose of the ASO. Here you see is a 30 cc's. And okay, so we are exactly here now. We are ready for, in October, will be the third application on day 112. So we hope to expand the program, and I hope to be able to tell you more about it. We are again more than excited. There has been so many years to get to the promised land. We think we have arrived there, and we are expecting to see what the results are going to be, and if we can expand the program. So stay tuned, and thank you very much. I think we have Alejandra now that will tell you about other clinical programs.
Hello, everyone. My name is Alejandra González Duarte, and I am the co-director of the Dysautonomia Center. It is a pleasure to join you celebrating the FD Day 2024. Today, I will be sharing with you an important update of the work that we've been doing at the center over the past year. If you have FD, or if you know someone who does, you probably heard about the autonomic crisis. They are these intense episodes that are a key part of the condition. They come out of nowhere. They are tough to go through, hard to watch, and really tricky to treat. There are a lot of questions surrounding autonomic crisis, like how to measure their severity, what is the best treatment combination, when will they happen, will they strike again? Even though these crises are so dramatic, they can be surprisingly very difficult to communicate and to fully understand. Thus, to address this, we've been working hard on designing a method to quantify the crisis and optimize the treatment for the best possible outcomes. Over the past year, our team has created a scale that could be reliable, easy to use, and that would provide the results that were easy to understand. We aimed for something simple enough to be used during the crisis, so we wouldn't have to gather information and piece things together afterwards. We evaluated many crises and identified the most frequent measurable symptoms. Each symptom was assigned a score ranging from 0, which was nothing, to 3 or 4, depending on the severity of the symptom. Participants were assessed during crisis and after treatment. We documented ongoing crisis or crisis resolution as determined by the patient or the patient caregiver. The average total score was 5 points, with a range from 3 to 7. What does this mean? Well, if a patient hit a score of 3 or higher, there is a high chance that the patient is experiencing an autonomic crisis. When the crisis was resolved, the median score dropped to 1, with a range from 0 to 2 points. This system gives us a really strong indicator to act quickly and confidently in an autonomic crisis. Then we created a web-based questionnaire, easy to answer and accessible by mobile, iPad, or any computer. We provide this link to everybody, and we will continue to provide so because we wish you can use it as often as possible because it will be very helpful for you and the community. Why is that? Because at the end of the crisis, the users can download a PDF for the records, helping them understand the pattern of the crisis, to identify the possible triggers, and to differentiate between the useful and not so useful interventions. At the same time, the center can track the crisis for each patient individually. And also, we can compare the patient data and make recommendations based on these findings. Now, in addition to the autonomic crisis scale, we will be using our knowledge to have this treatment optimization. As you all know, dexmedetomidine, known previously as Precedex, is the gold standard for stopping autonomic crisis. However, it can only be administered in the ICU setting because it's only available through infusion. However, a new commercially available form of dexmedetomidine was recently launched for the use in similar conditions. It is the same medication as Precedex, but it comes in the form of a sublingual film similar to Listerine breath strips. We thought, this will really be convenient for managing FD crisis because it's placed under the tongue, allowing fast absorption. It can be easily administered anywhere. And since it bypasses the digestive system, it won't be affected by vomiting in the crisis. Also, this form would also be ideal for patients who receive the medication through a G-tube, as the small bowel paralysis is common in the crisis and can interfere with the absorption. With the sublingual film, these issues will be bypassed entirely. To address this, we are currently conducting 2 clinical trials to evaluate the efficacy of this sublingual dexmedetomidine at home. All FD patients who have experienced at least 1 crisis per year are invited to participate. Remember, through these trials, we will confidently determine the best dose, the interval, and the timing of the administration, and we can compare it to other treatments. Also, and most importantly, these findings will provide us with the evidence needed to support its approval for prescription and for reimbursement. In addition to improving the care of autonomic crisis, we continue to provide regular medical care, administrative support, and overall assistance for FD patients 24/7. This includes writing medical letters of necessity, processing medication requests, and even providing legal testimonials when needed. We continue to create educational resources for patients, families, and care providers, incorporating the most current recommendations from the CDC, the FDA, and other regulatory medical authorities. We've been launching short, informative posts on our social media accounts to make it easy for you to share with your friends and family, so you don't have to repeatedly explain FD or its challenges. Our goal is to offer practical clinical advice, like answering common questions such as, how much salt should I be taking, or why should I be taking salt? We encourage you to follow us if you are not already doing so, and please feel free to share this post with your loved ones. If you have any questions, chances are that others have the similar ones. So please reach out to us if you'd like to include specific topics in our messages. Finally, but certainly not least, I want to remind you that the most important part of managing FD is having a strong support network that you can rely on at any time. We are happy to be part of that circle, but it's essential you have all your contacts ready and accessible. Remember, being independent doesn't mean that you have to be alone. It means that you understand that from time to time you will need that support. No one knows your body as well as you do. So please do not delay your care. Simple issues, if not addressed on time, it can be more complicated later. Our work is only possible because of you, and for that, we are really grateful. It is an honor and a privilege to be part of your clinical care, to witness your success, and to share the moments that shape your life. Your trust in us is something that we never take for granted, and we are committed to walking this journey with you, offering the support every step of the way. Thank you for allowing us to be part of your story. Now, we will have a Dr. Kazashkov talking about lung care in FD.
Good day. I'm Mikhail Kazachkov. I'm a pediatric pulmonologist. Thank you for inviting me and letting me to present during wonderful FD Day. I am an NYU physician. I work at NYU, and I am director of the Division of Pediatric Pulmonology. And I have to say that big part of my work and clinical effort is dedicated to treatment of respiratory problems in children with neurological, neuromuscular, and genetic diseases. And we have large clinic, which has more than 600 children and young adults with those disorders. So for me, it was only natural and logical to join Familial Dysautonomia Foundation as pulmonologist, and I been working with FD children and young adults for more than 10 years. And I'm very grateful for my fortune and for the fact that I met Dr. Axelrod and then Dr. Kaufman and then Dr. Gonzalez Duarte and all the wonderful team, and was able, I hope, to make difference together with them. I also want to say that one of the biggest parts, I would say, biggest successes in our effort was publication of guidelines for respiratory management of children and young adults with familial dysautonomia in 2018. But today, my presentation is called "What Does It Mean?" And the reason for that is sometimes I think we all, and me too, we talk to our patients in a way then it's a little bit difficult to understand. I'm not sure how to change the slides, unfortunately. All right, looks like, I managed. And here's the example what the doctors sometimes tell their patients. And I say those words and sentences myself often too, to children and their parents in familial dysautonomia clinics. I say, I think you have aspiration. You need to have video fluoroscopic swallow study. You also have obstructive sleep apnea, and you need to have polysomnography. You may need to sleep with BiPAP machine. And when I look back and I think, what am I talking about? Is it really clear to my patients and their parents what I am trying to say? And I read this sentence to one of my patients, not with familial dysautonomia, but with other disease. But she is a very smart 9-year-old, and she said that she thinks that this is, again, I'm sorry, I cannot change my slides. And she felt that she thinks that this is abracadabra. And you know what abracadabra is? Abracadabra is the language of magicians, which does not make any sense to common people. And I certainly would like to avoid abracadabra when talking to you. And that is why today I created a little vocabulary of medical terms, which we use often in children with familial dysautonomia. The first word which we would like to comment on is the word aspiration. And aspiration could be from above, and that's when the child eats. And that's the cartoon which is supposed to work, but unfortunately it's not working. Let's go back to your screen then. Okay, so back to the screen. Can I see the previous slide, please? Mm-hmm. Yeah, so aspiration could be divided into three different processes. One is aspiration from above, and that's when the child eats. For example, sucks milk, and milk, instead of going in the stomach, sometimes goes in the lungs. I'm sorry that the cartoon is not working. And it's probably the type of aspiration which children with familial dysautonomia have most often. And also, we shouldn't forget about aspiration from below. And aspiration from below is when the child already ate something, and then for some reason, instead of staying in the stomach, it comes up all the way to the mouth and then down to the lungs. And then there is another type of aspiration, which is very rare, and it's called aspiration because of an anatomical problem. And it's when there is connection between trachea and esophagus, but it's not a common thing, so we don't need to worry about it as much. May I have next slide, please? So what is bad about aspiration, of course, and that is why we talk about it all the time and so much, is that when aspiration happens and milk or other food, doesn't matter what one, even which food, even water and even juice, goes in the lungs, it carries a lot of bacteria, and bacteria are certainly not good for the lungs. So that is why we don't like aspiration. That is why we talk so much about aspiration and the ways to avoid it with our parents and patients. Next slide, please. So in order to find out more about aspiration, we do this study, which is called the video fluoroscopic swallow study, which was another part of my medical sentence. It's also known as barium swallow study. And that's the study when the child or adult to this matter eats something by mouth, and then this food is mixed with contrast material so that we actually can see where this material follows, whether it goes where it's supposed to go in the stomach, or sometimes it makes all the way to the larynx or to the trachea, to the wrong tube, and then to the lungs. So this is an important study which we often recommend to do to our patients with familial dysautonomia. Next slide, please. Next word in this abracadabra sentence was obstructive sleep apnea. Sometimes we even call it OSA, like abbreviation. It becomes even less clear what it is. But in reality, this is the condition when the child or adult goes to sleep and then starts snoring. And everybody hears that, and snoring comes from the mouth and nose. But in reality, if you could take a camera, which I often do, and look inside the nose and mouth, I see that nose and mouth inside join in the little sac, which is called pharynx. And this is here on this slide. And as you see, it's open, and there air goes inside the pharynx and then to the larynx and to the lungs. But sometimes what may happen is that during deep sleep, the child or adult, doesn't really matter who, may be in the situation when pharynx closes in, as you see here on this slide, and becomes really tight. And it happens because during sleep, we all lose control of our muscles and the pharynx starts closing. And that's where the air stops moving in. And instead of moving in, it starts vibrating right here, creating all kind of vibration and sound. And we hear it as snoring. Okay, so this is something which we would like to investigate. And because of that, we do, please, next slide, something which is called polysomnography. Polysomnography, if you translate it from Greek, it can be easily translated as sleep study. And everybody understands now what it is. So it's another difficult word, but in reality, this is the process when the child, and again, adult, falls asleep, and then the special technician in the room, in the sleep center, hooks up, it's called, the patient to special monitors. As you see, there is nothing invasive. Little stickers on the head, little behind, underneath the nose right here. And then there are some stickers which go on the body. They are not painful, and they are merely stickers. And then the child or young adult or adult sleeps, and then we start seeing something on the screen which is called recording of sleep study. Let's take a look at it together. Next slide, please. So this is a recording of sleep study. And let's look right here. This is the recording of air coming in and out from the nose. And you see right here, it looks a little bit like a saw, but in reality, it's air coming in and out, in and out, in and out. And underneath here, there's a recording of movements of the chest, which correspond to breathing. You see air coming in and out, and then the chest moves out and in, out and in, out and in. That's how we breathe. But let's now pay attention to this part, which is kind of painted in pink, right? See here, you see that, you know, the movement of the air in the nose in and out stops. And now it seems like air is not moving anymore. Nevertheless, the chest continues moving. So if you didn't do the sleep study and just looked at the patient at this moment, you would think that the patient is breathing because the chest is moving. But what you do not know is that at the same time, the throat is closed, shut, and the air is not coming into the lungs. And if you look at the curve down here, the lower curve, you will find out that when it starts happening, the oxygen in blood starts slowly going down and dips down pretty low, which is not good at all. And that is why we don't like those events of obstructive sleep apnea, because they cause problems with oxygen, which we need for our body. Next slide. That is why sometimes the physicians say, now you need to sleep with BiPAP. What it means in reality, it's the special machine and the mask, which can, like a little ventilator, push air through the nose or through the nose and mouth in the throat, open it up, make it a little bigger, and stop obstructive sleep apnea from happening. It's a very, very efficient way of treating obstructive sleep apnea and children and young adults and older adults who wear the mask with BiPAP usually do not have any problems with obstructive sleep apnea and with oxygen. I'm not saying that wearing BiPAP mask is very easy, and many of you know that it's not easy at all, but I always want to say that it's very, very much worth to try and to do it because it helps with oxygen and helps to treat this bad condition, which is called obstructive sleep apnea. Next slide. Now I think it makes more sense. And all these words, aspiration, video fluoroscopic swallow study, obstructive sleep apnea, polysomnography, and BiPAP machine are a little bit more clear to all of you. And I am very happy that we all can work together, do our tests, make you better, and after all, make all the population of children, young adults, and older adults with familial dysautonomia much, much healthier, which means much happier. Thank you very much for inviting me today.
Hello everyone, my name is Lily Armstrong and I'm a licensed professional counselor. I've been working with the FD Center to provide mental health counseling since 2015. When I started this work, I was in an internship living in Lower Manhattan and finishing up graduate school. Now my family and I live in the Pacific Northwest, where I work with all of my clients virtually, either by phone or by computer. Let me back up for a minute and tell you the story of how this got started. So one of my first clients was a very special man named Stevie Schwartzberg. He lived an amazing, wonderful, but too short life. His parents and sister wanted to honor the legacy of this wonderful person and did so by creating a memorial fund in his name to support access to a mental health clinician. Through the generosity of their time, vision, efforts, and funding, they wanted to continue supporting mental health services for the entire FD community. I am thankful for the Schwartzbergs and many others for the opportunity to do this really rich and meaningful work. Living with a chronic illness and living in our current culture can have significant impacts on our mental well-being. One of the direct impacts is how intense we experience anxiety. Anxiety is likened to a smoke alarm. The alarm itself is notifying us that something in our lives is disjointed or disconnected. Sometimes this alarm is telling us that there is a present concern that needs to be addressed, and other times this alarm is challenging us, reminding us of what's important or alerting us to a future potential. When I'm experiencing anxiety, which is quite frequently, I like to do a visualization exercise. I remind myself, or I ask myself, when was the last time I felt really content? Lately, for me, it's been in my hammock, enjoying a good book, just enjoying the wind in the trees, right? And when I'm there, I give myself permission to be present in the moment. Now, it doesn't change any of the external circumstances or current stressors that might be coming my way, but in that moment, my whole body can feel a source of contentment. One of my goals with each client is to discover what their source of calm is. If you identify this, you can live and act out of a place of values versus a place of insecurity. I like to use an acronym for this. I like to use the word peace. So P stands for being present. It means to be aware, to be in the moment. One of the great opportunities of therapy is help challenging situations come into awareness, to create a safe space where you can be present to your life's experience. You can unmask a little, acknowledge the impact of situations and feelings on your mind and in your body. The E is explore. See problems as opportunities. How can we invest in our growth? Exploration is when we start to ask some of those questions about why, to evaluate the impact of our past successes and challenges on our current life. I like to say, never worry in your head. Write these things down. Find a safe person to share them with. Exploration is great when it's done with others or in community. A is for allow. Therapy is a partnership, and it can co-create an internal sense of safety. Sometimes we have to allow some of the hard feelings to be more present. That way we're not so overwhelmed by them. We want to practice feeling more, not feeling less, even if those feelings are big, intimidating, or at times overwhelming. Avoidance can feed anxiety, and it tends to shrink our life instead of expand it. C stands for curious. We approach even our own mind and heart with grace and curiosity. Curiosity helps us look at mental blocks in a productive way instead of a catastrophic way. It makes us open and receptive to the process, seeing new ways of doing things, and helps us get into our creative selves. Curiosity can also help us visualize a successful outcome instead of a catastrophic one. And last, E. E is expand. We expand our thinking, our empowerment, our advocacy, and our agency over our thinking, our feelings, and our behaviors. Expanding our internal ability to engage with anxiety gives us resilience in a way that helps us invest in our lives in the ways we find most meaningful. Creative, engaged, giving, gratitude. My hope for every person I work with is that they get to build into this sense of peace. I look forward to meeting with you, engaging with you. I'm an advocate for all mental health resources. If you have questions for how a loved one is impacted by this illness, I'm here to help. Please reach out if I can be of service to you. Thank you for including me in today's event. I've loved sharing this space with you. Thank you.
So thank you again to Dr. Kaufman, Dr. Gonzalez, Dr. Kosovskov, and Lily for sharing your expertise with us today. We're incredibly fortunate to have such a dedicated team caring for our community. Next, we're going to explore FD around the world. We will be hearing from Dr. Maru Briceño, a neurologist from Mexico City, Dr. Bat Albar Aluma, who is a pediatric pulmonologist from Israel, Dr. Valeria Ayodici, a consultant in neurology and autonomic medicine, and an associate professor from the United Kingdom. And last but not least, we will hear from Dr. Margarita Robocopatel from Argentina.
Hello everybody, this is Dr. Maru Briceño. I'm a neurologist from Mexico. If you remember me, I was an invited professor at the Dysautonomia Center in New York City in 2022, where I had the privilege of knowing and learning from all of you, the FD community. Back in my country in 2023, I started a dysautonomia clinic in Mexico City, the second one, to give adequate care to patients with autonomic conditions, including FD, to do research, and to teach dysautonomia to other medical students and neurology residents. The clinic has gone well, but now is about to be led by another neurologist who is going to be trained at the Dysautonomia Center in New York City, as I was. I moved to Guadalajara this year, the second largest city in Mexico, where I am leading the new neuromuscular and autonomic clinic in my current hospital. I am really happy to say that just about a few months ago, we've got the local government approval to properly equip this clinic by next year. In Mexico, there are 3 patients with FD located in different cities, but in close contact with us. We actively participate in advising their parents and their local physicians as by telehealth as often as they need it. One of the biggest obstacles we have faced was the limited resources to bring these patients for in-person consults. And one of the biggest challenges has been convincing other treating physicians to be extra careful with decision-making, procedures, and medications, and to be aware of FD crisis and lack of pain and how this could impact the outcome of FD patients. FD patients are extraordinary and they need us to do an extraordinary work. I'm so happy to see how this important task of creating awareness in Mexico has been taking shape, but there is still a lot of work to do.
Hi everyone, I'm sure everyone knows me from previous FD days. First of all, I want to thank all the organizers that manage every year to unite us in this marvelous day of knowledge, innovations, and new research. I feel very fortunate to be a part of this day. And like every year, I'm very excited to talk to you, families and friends. I was asked to talk about how my clinic fits FD patients with their unique necessities. However, I decided that this year I'm going to talk about how the Israeli FD patients bravely cope with our situation here in Israel, living in a country that is at war, with a hostage situation. More than 100 kidnapped are living today in captivity under the ruling of Hamas. And unfortunately, death surrounds us almost every day. And no doubt, this is a very, very stressful situation. And I see it every day. I see that more anxiety, more FD patients want to start medication against anxiety. There is an increase in FD crisis. And all of these are features that are related to our situation, a very unique situation. So I'm going to talk about collaboration that we do with our psychiatrists to how to start these medications, and I will give an example. At the beginning, we started the SSRIs, like Prozac, for example. We started on a normal dosing, like half dose for 1 week, and then we increment for full dose. But in this was not suitable for FD patients, and we saw 2 cases when with the initiation of the medicine there was a severe hyponatremia, which means very low sodium in the blood. And so recently, when we start this medication, first we consult with the psychiatrist of what drug is more suitable for this patient, and then we started on 5th dose, and every 3 days we take electrolytes in the blood with close monitoring until we reach the therapeutic dose. And I have to say that this way we haven't seen any side effects, and it works beautifully. So I want to thank you all for giving the chance to talk, and I want us to have a great FD Day. Thank you.
Okay, so first, really thank you to everyone for inviting me. Such a wonderful event, extremely important for our patient with FD. And I'll give you a brief overview of what the Autonomic Center in London does provide, and how we are trying to improve actually the service at our center. So the Autonomic unit in London is obviously all the care, it works around our patient. There are 4 consultants, there are specialist nurse, researcher, and autonomic scientist. And this is just an overview of the disorder. So we have more or less more than 5,000 patients that are seen at the autonomic units in London. And the reason why I'm mentioning that, because we learn from our patient. So you will see an highlights on the autoimmune autonomic neuropathy. It's one of the rare disorder. And what we did learn from our patient, and we are hoping actually to offer to our patient with FD, in particular regarding the policy within the NHS. So at the Autonomic Center at UCLH, so what this multidisciplinary team at the center might means for our patient with FD. So if there are patients, then they are under our care. So they know that they might have been seen in clinic, but one of the autonomic consultants, they will be reviewed by our specialist nurse and discuss also the topic regarding rehabilitation. They would have been tested with specific testing looking at autonomic function, cardiovascular testing, maybe pseudomotor testing, urology testing, or testing looking at high function. the complexity of the care, and this is where we are finding a little bit of challenge, and we communicate quite often with and we are grateful for that with the center in New York to be guided regarding how we can improve the provision of the care, is then, as you have seen in the meeting so far, the management of patients with FD goes very much beyond the autonomic neurology. So the complexity of the problem require really a multidisciplinary team involving several disciplines. So you have seen the importance of sleep and pulmonary medicine. Patient will need to be seen by a neuro-ophthalmologist. It's important the physiotherapy, the input from our specialist nurse, gastroenterology, nephrologists in some of our patients, and obviously extremely important the psychologist and the emotional support, which we had just a wonderful talk just earlier on. So the management is so complex, then it cannot be delivered just by one center. And some of the patient might have be seen as specialists within the same trust, so within the UCLH, but it's not always straightforward because some of the patients, they might have a specialist outside our trust. And this is the challenge then we are trying to address. And this is why the highlights then you see regarding the autoimmune autonomic neuropathy. So from these other rare disorder, what we have learned from our patients, this is another group of patients and they require very, in a way, intensive and sometimes invasive treatment. Long-term, the autonomic nervous system is affected, unfortunately, at several domains. And so, as you can expect, several specialists will be involved in the care of this patient. So with this particular patient group, we have challenged the process at the NHS, and a few years ago, we managed actually with a multidisciplinary core pathway to change the policy. A new treatment now is available to this patient, and we have been able to establish what we call the national clinic. So patients are seen every 3 months. Consultants that are not necessary within our trust, they can join us in a multidisciplinary team which runs on a Wednesday morning. And this is what we are trying to, in a way, offer to our FD patients. So we are hoping that actually there can be a good collaboration between the team at our center, but all the other specialists, and it will be an MDT. So at the moment, already few patients actually they have been discussed. So that means then, for example, in a complex case where a nephrology input is absolutely crucial, if the nephrologist, so the specialist looking after the kidney, is not within our trust, the specialist can join us remotely in a multidisciplinary team meeting. We can discuss the care, we can involve the GP, we can involve the patient and caregiver, and this is how we are trying to improve the care. And obviously, as you can imagine, and as you have heard also from the clinician from other countries, the complexity sometimes is convincing also the government and changing policy. And these are for us few key points why really we are an advocate for multidisciplinary team meetings, why we need that for our patient for FD. So it does definitely offer a better integration of patient and caregiver needs. Quite often we discuss in clinic and I ask my patient, what are the needs then actually beyond the autonomic problem we haven't been able to needed to address or to achieve, and is with their feedback then actually we are able to approach the GP and involving the other physician. Definitely a better communication between teams members, increase access to services, because sometimes the GP might be limited in the service then they can access locally, and this is where a tertiary referral center like us, we will need to support and help. Improving the knowledge and the awareness of FD in UK, and quite important, training the next generation of experts in autonomic neurology. To keep in mind that then autonomic, fortunately now is a core of the training of all our SPR in UK, but you can imagine it then is a quite a niche field. So not many neurologists actually they've been exposed for a long time to the management of complex disease, and definitely also the research collaborator. And again, we are grateful to our link with the New York team. Thank you for your attention. Thank you to all our patients. And yes, if you have any question or things, then I have not addressed in this talk.
Hello, everyone. My name is Margarita, and I'm a research scholar at the NYU Dysautonomia Center. I first arrived to the center in September 2023, so it's funny because it's actually exactly 1 year ago today. And since I joined the team in the center, I have gained extensive knowledge about the complexities of FD and all the management strategies. I have had the opportunity to work with amazing, very knowledgeable and capable physicians, nurse practitioners, and scientists that have taught me so many things. I have also witnessed them work tirelessly, paying meticulous attention to every detail to make sure that everyone is being taken care of. I have shared with them achievements or milestones in care, and I have also shared very difficult losses. But what has been more striking to me about this opportunity is not the medicine or the science itself, but the people. I have found a very vibrant and amazing community among FD. I have seen how people, despite the daily challenges of living with FD, are still very committed to pursue their dreams or their passions, whether it be painting or writing or playing video games or spending time with the family. I have seen how people are still fully committed to doing what brings them joy. People like Pete, Mara, Simi, Jackie, Gabi, just to mention some of you guys, have taught me how life can be so beautiful if you're really paying attention, and how communication can take many forms too. This opportunity has been very important for me because it has opened my eyes to the type of physician I want to be. I'm about to start residency, hopefully. Next year I will become a neurology resident. And I really can say now with a lot of certainty what type of doctor I want to be in the future. You have taught me that I don't want to be a doctor that also only pays attention to medicine or science, but also to the people that is behind the condition. You have taught me that a person is not defined by the condition, but by their passions and talents and dreams and aspirations. And I am now more committed than ever to be a physician that has an holistic approach to patients, that can see them, who they are, what they like, and what makes them happy. So I'm deeply grateful for this opportunity to all of you and for welcoming me to this amazing community. Thank you.